welcome everybody. My name's Katie McClure and I'm lucky enough to be the chair of the British Computer Society Health and Care Scotland at the moment. And we always welcome new members. We love to have other people coming along to the committee. And one of the main things I like doing is organising talks from different healthcare professionals and from social care too. So I was absolutely delighted to read about the Scottish Radiology Transformation Programme as it was at the NHS event in Scotland this year. And we're very fortunate that we have along today Jennifer, Maureen and Adam, who are going to tell us all about their roles and what it is they do, and particularly to focus today on that Scottish Radiology Transformation Programme in Scotland and the adoption of CDS and AI within that service. So welcome everybody, and I shall hand over to, I believe Jennifer's going to kickstart.
Good afternoon everyone. Thanks for joining and hope you're excited to hear about the Scottish Radiology Transformation Programme. I'm the project manager for one particular project, which is the Scottish National Radiology Reporting Service, and I'm joined by two of my colleagues who I'll just let introduce themselves now. Mo?
I'm Mo McGurk. I'm the Service Implementation Manager for the Scottish National Radiology Reporting Service. I come from a clinical background in radiology and have just recently moved into a more IT-based background. Adam?
Yes, good afternoon. I'm Adam Pinner. I'm the Project Manager responsible for the Clinical Decision Support and Artificial Intelligence projects.
Thank you. So what we're going to do today is just give you an overview of the whole programme, and then we're going to go into a little bit more detail into AI, CDS and the Scottish National Radiology Reporting Service, which we call SNRRS, or some of the boards actually call it SNRRS, but for us we'll probably keep it as SNRRS. So hope everyone can see this, and this is just a bit of background as how the programme came around. So radiology services have been under increasing demand for the last 10 or 20 years. And here's just some numbers about it. So 90% of all patients in hospital are supported by radiology services. They've seen a 3.4% growth in demand. There's not enough consultants. The numbers here are from 2018-19, where we think there was a 31% shortfall across Scotland, with nearly 8,000 patients waiting over 6 weeks for radiology exams. So any CT, MR, X-ray and all the other exams. £14.5 million in 2018-19 was spent on outsourcing. Outsourcing being where we send exams to third-party companies to do the exams, to report on the exams for us, because there's not enough capacity within the normal service. So overall, these numbers are not going in the right direction, they're going in the wrong direction, and it means that this service isn't sustainable. So that was why the Scottish Radiology Transformation Programme was agreed to start up a number of initiatives to try and rebalance or at least help that problem. So there's a few parts to the programme. Technology and innovation, one of the big things for this was around IT connectivity. So every single health board in Scotland has got a radiology information system, and years ago, well, still now, those systems don't talk directly to each other. And there's a huge IT connectivity programme which enabled the radiology information systems to be able to link together through another application called Share Plus. So this has been a huge piece of work, and we'll talk to you a bit more about that upcoming in the presentation. In terms of new service models, so the SNRRS is one of the big new service models where we've actually developed a virtual bank of radiologists to do this additional reporting that I just mentioned in the previous slide, and still out of hours, but within the NHS, so that we're not paying third-party suppliers as the middleman between us and getting the reports done. In terms of a sustainable workforce, there was new radiographer places that were agreed as part of the programme, and this was a huge win because the radiographers are the one that support the radiologists, and there's actually a group of reporting radiographers who can actually report on exams, mostly plain films, but they make up the majority of the exams that are done in the whole of radiology services. A huge bit of work that was done was around our vision and target operating model for radiology, and we were lucky to have that signed off just recently. So if anyone wants to know anything about that in the chat, please put some questions in and we'll answer them at the end. But I'll just hand you over to Adam, who's going to talk to you about AI and CDS.
Thanks, Jen. Yeah, so under the using technology effectively, it's specifically with AI, it's not about replacing people or taking jobs away, which is one of the concerns that has come out in terms of workforce. It's more about utilizing technology to make better use of the capacity and the resources that we have at the moment. Within the SRTP, we're sort of focused on three main areas. This does include piloting. So we are looking at some of these solutions and products that are out there, and we're looking at them specifically, the ones that are going to probably deliver quickest fixes or the fastest results in further down the line. The thing about AI is that there's a lot of it out there. It's in various stages of development. Some are well funded, some are not so well funded. So things are changing quite rapidly. So it's actually quite difficult to keep a static grasp on all of the technology that's out there. But what we're specifically aiming to do within our project is look at where AI will fit within radiology, how it will improve these services, and most specifically patient experience. We want to look at a nationally developed approach to the deployment and implementation of AI solutions. This is obviously going to be more paper-based and theoretical, but it will run alongside pilots that we do actually have in place. And because AI is a hot topic and of wide interest, we're trying to maintain a national register so that we can see what everybody else is doing within academia, anybody linked with the NHS. So within our NHS, different boards, and also in academia around the NHS, so that we're not sort of jumping over each other or treading on each other or duplicating work. So down the bottom there, you'll see a very sort of basic scope that we're working towards, which is looking at the planning. Education is very key, because I think the more that people are aware of what AI can do and where it fits, the more adoption we will get. And also with the piloting, as I was mentioning before, it's deciding what to pilot and where. So one of the other surveys that we're doing is a needs analysis within radiology. The other thing, of course, that comes with all of this is that there needs to be a proper approach to it. So the evaluation and validation of the results that come out of any AI project, they need to be properly recorded and documented. So we've got a whole process around that as well. Next slide, please, Jen. So one of the things that is key is not just putting in the technology, but it's obviously having the right people around it to ensure that it is done properly. And so, for example, within our team, we've got project management. We've also got a consultant radiologist as our clinical lead and steering group chair. And within our governance group, our steering group, we've got representation from a wide range of individuals, radiologists, radiographers. We can see them all there. I don't need to spell them all out for you. We've got people from universities, innovation. That's quite important, because there's always, we need to be careful when we're piloting things so that we're not giving people a bunk up. So there's a whole thing around procurement and how these things are actually piloted, and so that we are following rules and giving everyone a chance as they come down the route. Next slide, please. So as I was mentioning before, what we've got going on at the moment is we're doing a needs analysis. And this is to survey, looking at pinch points and looking at areas that we want to focus on in terms of products. We also need to be looking very carefully at how the evaluation and validation will work. Cost efficiency is a big thing, as well as governance and ethics, and also the role of adoption. So there's going to be patient engagement, staff engagement, that sort of thing going on around this. Some of the areas that will be of interest in terms of the technology, one of the things that we are looking to pilot, which is currently going through governance, is a chest X-ray product, which is aimed at speeding up the lung cancer pathway for patients. So what can often be the case is an X-ray is taken, say you go to your GP, an X-ray is taken, the X-ray will then go off into the consultant radiologist department to be read. It may or may not get prioritized. It may take a little while to get read due to how busy everything is. What this product will do is it will be able to very quickly, within seconds, determine whether there is an anomaly on the lungs, and potentially then gets the person booked in for a CT scan and more detailed investigation straight away, potentially same day. It also has the capability of passing normal scans as well. So as part of this pilot, the idea will be that 15% of the chest X-rays will be passed as normal, and they will not be seen by a radiologist within the board that is trialing this. They will be seen by a radiologist that is working for the AI technology company. So we will be able to determine how the automatic passing is actually working. The other areas that we're looking at is the assisting of reporting of X-rays and CT scans. And this has sort of helped the consistency and quality, excuse me, of reports being produced, so that errors are seen, found, and corrected, so that everything comes out the other end correct. So that's where we're currently at with the AI project. There's quite a lot more to do, though. Next slide, please. So I'm also responsible for clinical decision support. We are looking at the demand regulation and patient safety. These are the two key areas. Demand regulation is to protect the radiology service, and in return, making sure that the patients do not get unnecessary, I guess it's unnecessary stuff being done to them in terms of radiation, in terms of procedures, etc. So we are trialing the project amongst two health boards. One of them is just purely GPs, primary care, and there is a selection of ultrasound, CT, MRIs, and X-rays being done there. The other board that is piloting it is primary and secondary care, and again, ultrasound, CTs, and MRIs. And again, with all of these, we need to ensure that we've got the right people around this. So we've got a consultant radiologist, the clinical lead. We have someone from academia who's a lecturer in diagnostic imaging working on the evaluation. And then there is the project team. In the boards themselves, we've got the consultant radiologist, we've got the IT systems managers, we've got the service managers, and we've got some GPs as well. And then we've got a medical director who's overseeing it, as well as the other list of people there who are sort of involved. Next slide, please. So this is a very basic diagram, I guess, of how the process works. So patient goes to a requesting clinician, and let's say, for example, this would be the GP. They would use something like an order comms system to make a request. This is where CDS would intercept this process. So CDS would then pop open a window. The patient's troubles would be presented, and CDS would then determine what the best course of action is. Now, CDS uses the Royal College of Radiologists I-refer guidelines. Now, these can be what we would call vanilla, which is as they stand when they come from the RCR, but also they can be adapted in order to meet the requirements and learnings from each of the local boards. So then the next step after CDS has been there is, under normal circumstances, a vetting process would take place, and it would be it's accepted, rejected, or more info required. It takes about 30 seconds on average to do a vetting, go through the vetting process, unless it's more information required. And this is where things could be time intensive. And this again is where CDS could help. So if CDS is used to green light orders and requests, then you're taking up less time from a radiologist. And from there, it gets shunted through to the radiology information system, which is what places the order in the hospital. Next slide, please. And I think what the pilots that we've got haven't actually been generating any data yet. They're still in the process of deployment and implementation. But what we have seen is the results from tests or from implementations in England. And as you can see there, we've seen 8% improvement in referrals. And when I say appropriateness, this means the right referral is making its way through from the doctors to radiology, which is what we want to see. We've also seen a 4% average cancellation of unnecessary referrals. This is where effectively where a referral was going to be ordered and then is found to be unnecessary. Nothing has been ordered. There's a huge amount of cost avoidance saved there. And we've also seen, as part of the vetting process, 2,500 hours of radiologist time potentially to be saved through vetting. And that's me. Thank you very much.
Thanks, Adam. I'm just going to move on to Mo now.
Hi, so as I said, I'm Mo, so I'm responsible for the IT connectivity implementation across Scotland and also work alongside Jen on the implementation of the Scottish National Radiology Reporting Service. So in radiology departments across Scotland, there's two main clinical systems. There's a RIS system, which stands for Radiology Information System, which is used for the requests coming into a radiology department, managing those requests, getting them vetted, making bookings, all the letters being sent out to patients for those bookings, managing patient lists on the day, and managing documentation around those lists. And in the majority of boards in Scotland, the reporting of radiology exams is still performed in the RIS systems. The other system that's crucial to radiology is the PACS system, which is Patient Archive Communication System, which is basically a big system that stores all the imaging from radiology exams across Scotland. And in 2007, a national PACS programme was put into place, which joined all health boards in Scotland and allowed them to share patient images across Scotland. So we were one of the first countries in the world to do that, to link our whole country. And the reason why we could do that is because we have a CHI number, the Community Health Index, and all boards use that. So because we have one patient master index number across Scotland, we're able to share imaging across Scotland. So that's been a really successful programme, because it basically means you can take an image at one hospital and 2 seconds later somebody can look at it at another hospital in another location, and you can have multiple people looking at the same images at the same time. So that was all well and good, and Scotland's moved forward with that and now just accepts that they have a national PACS system. But currently within RIS, each board has its own RIS systems which don't talk to each other, which means that there is no cross-boundary reporting ability. So clinicians, if an exam's done in Glasgow and somebody wants somebody in Edinburgh to report it, prior to the IT connectivity system being put in place, then that would be, they would phone them up or send them an email saying, can you look at this patient with this CHI number? This is the exam, and they would get an email sent back with a report to cut and paste into their own RIS system. So the idea of the IT connectivity system was in order to create a cross-boundary reporting system. And in 2017, we went out to tender, and it was a company called Soliton that got that tender with a product called Share Plus. And what that allows us to do is it allows us to do cross-boundary reporting. So if an exam's sent to the Share Plus system from any RIS system in Scotland, it can be reported in conjunction with the national PACS images, and then that report electronically delivered back into the local RIS system. Next slide, Jen. So this is a diagram really of how it works. So on the right hand side of the screen, we've got the National Share Plus. The top RIS is for a multi-PACS board. So that might be a board like Glasgow, where RIS 1 is. So they have one RIS system and they have several PACS systems. All the PACS systems lead to the national PACS system. So regardless of what site you're on in Glasgow, you can report images which are done in Glasgow on one RIS system. But as you can see from the dotted line round about it, it previously wasn't able to be reported out with that board. The middle board would be a board, so RIS 2 would be a board like Borders that's just got one RIS system and one PACS system and can't function out with Borders for reporting. And the bottom one is actually Highland. So Highland's one of these boards that part of Highland West used to be part of Glasgow, their Gowland Butte bit that's in Oban. And when they moved to being part of Highland, they took their old RIS system with them. So currently, even within Highland Board itself, they have two RIS systems working very independently of each other. So they're not even able to cross site report within Highland Health Board between Argyll and Butte Hospital and Raigmore. So what the National Share Plus has allowed it to do is it's allowed each of those RIS systems to independently assign exams to the Share Plus system. The order goes up to the Share Plus system where it sits on work lists that are managed by our workflow managers. And if there's any paper request cards or scanned documents attached to that, those will go up as well as the last 2 years worth of reports. Our clinicians then come on who work for us. They can report from anywhere in Scotland and they can report those exams, and those exams are then sent back to each of the individual RIS systems and able to be then fed down to downstream systems that will share the information with other parts of the hospital, and they all link to the national PACS system. So all reporting on the National Share Plus is done through the national PACS system. Jen, next slide. So this is just to kind of show your progress to date. So as with all IT projects, it's very difficult to get board resource in order to support your local national projects. So local projects obviously all take top priority, and during times of COVID this has been especially difficult. So although we started the rollout of the IT connectivity in 2018 and thought it might take us 1.5 to 2 years, we now find ourselves nearing the last quarter of 2021 and with 3 boards still to be signed off. So on the right hand side, everything that's in green is all the boards that can report for us. So any radiologist that's signed up to our bank and has access to the Share Plus client can report for us from anywhere. You'll see that Western Isles is grey, and the reason for that is that up until a couple of weeks ago, Western Isles hasn't had a permanent radiologist, so there was no need to connect that board to report for us, but we will be sorting that out in the coming weeks. On the left-hand side, these are boards that are able to donate. So currently the boards that are in blue are all donating work to us rather than sending them through third-party suppliers. They're all connected and have the ability to send work to us on a weekly basis. And the boards in green, that's Fife and Lothian, are boards that are connected but don't have the need to outsource work to us currently. And the 3 boards in yellow are all still within project, and that's because 2 of these boards chose to change their local RIS system halfway through the project and are still kind of embedded in that. And Lanarkshire, we're hoping for clinical sign-off next week. So we hope that by the middle of September, that board will be blue. Just going to pass over to Jen now to talk about the Scottish National Radiology Reporting Service, which the IT connectivity project has enabled.
Thanks, Mo. So we needed to run the service, we needed the IT connectivity project to have been done so that there was the ability to do the cross-board reporting. So these are just our main objectives. So the first one is to provide an effective alternative to outsourcing of radiology exams for the health boards. And we've called this part of the project the SNRRS Bank. And this is where we've set up a virtual bank. We've recruited radiologists from NHS Scotland to do those reports outside of their contracted sessions, which leads on to the next objective, which is to utilise existing reporting capacity across Scotland. So out of the 360 or 370 radiologists, we've got 60 of them working for us now. Providing a flexible reporting model for additional work. This and coupled with the consultants working from home were really two big asks of the radiologists when we first started this project. They didn't want to be tied down to doing sessions or doing shifts online, and they wanted to be able to report from home to help with that flexibility. So we have done both of those. So consultants can report any number of exams that they want within their own free time, and we pay them for it. And they can also work from home. So we have 85 machines within Scotland now. Their first, their main usage is SNRRS reporting. And the final objective was to explore ways to create subspecialty networks. So this is really where, for example, there could be neuroradiologists working across Scotland, and they want to talk to someone working on a different health board. How can we enable them to work as a group and have the functionality for them to view and share exams between them, which we've started. So this is just our roadmap of the bank. Really, so in order to be able to have a bank, we needed to have a host board. We needed some actual health board, not one of the special boards where NSS and where our project sits. We need to have someone with a board with the clinical governance and the hierarchy all in place. So the Jubilee offered to be our host board back in July 2019, which was really, really good news for us, and they are still our host board. And just to pick out some key things, so straight after that in August, we purchased our first 10 workstations to work at home, massive milestone, and a massive milestone for IT to actually have the workstations working from home as well. So we increased the number of reporters and workstations right up to the yellow circle. So for March 2020, COVID hit, and we were able with our workstations to donate 32 of those to radiology departments across Scotland as part of the COVID-19 response. So we'd had 50 authorised and we gave 32 away, which was good for radiology services, not so good for our project. However, we did manage to get budget to fund those. So now we essentially have 50 workstations that we had budget for, and 32 are now within radiology departments across Scotland. Some of them are being used for SNRRS and some of them are just being used for normal daily tasks. And then really since COVID started, we've just been building and building. So with radiologists shielding, people isolating, people caring, people being at home and not able to go to the hospital, the demand for our workstations really grew. One big advantage to our workstations is that the radiologists, as long as they had agreement from their board and the IT was able to work with their different systems, they could use our systems for our workstations for local work. So even though to qualify for a workstation, we only asked that the radiologists donate 4 hours a week to our service, they could potentially use the workstation for local work, and that's really been very, very well received. Along the bottom line, there's just a few of our sort of big milestones, with 100 hours a week donated from boards in October, and then ending up in June where we've completed our pilot. We have 60,000 exams reported, which roughly works out about 300 hours a week. And that was 10,000 hours for the year. And we've cost avoided boards because otherwise they'd have to go to the outsourcers, about 550k, which is really good for the NHS Scotland. This next slide just talks about who's involved in the service. So we have the team who I mentioned earlier. We've got workflow managers, workflow support officers. Their main objective is to manage the system. So we have donating boards. You can see on the right hand side, they send exams. So when you saw the IT connectivity slide from Mo, most boards are now sending us exams to be reported instead of sending them to third parties. Like the big thing that I forgot to mention earlier was that is NHS Scotland radiologists that are working for the third parties. So essentially what we've done is create a service that cuts out the middleman. And we've had really, really good feedback from the donating boards around the quality of service. They like the fact that it's NHS Scotland radiologists who are doing the work. They're happy with our turnaround times, and we've really struggled to get any negative feedback, which is really, really good. So they send all the exams into the system, and the workflow managers balance out the capacity of the radiologists with the demand that's coming from the boards. And this is a big job because there's different types of exams. There's some specialist exams. Boards aren't always sure exactly what work they have to give. And radiologists, of course, they don't have to sign up for a shift or anything. So we ask them in advance, roughly what is your availability? And it's the radiology, the SNRRS team to work to balance those two things, which works for the majority of the time. So in terms of the radiologists, just looking down to the box, it says about the reporter pool. So it says they're based across Scotland. They're actually based across 10 health boards. Majority are in Glasgow, purely because it's got the biggest population and the biggest population of radiologists. But there are radiologists dotted all over the country, working at home workstation. And this has been a huge achievement in terms of the IT connectivity to allow this, because every single board is set up differently and every single board needed tailored decisions and requirements to enable this to happen. Again, our host board, it's really important that we did have one of these because all the consultants have got a bank contract with the host board. So they essentially have two contracts. They have one with their substantive board where they work, the majority of them are Glasgow, but they'll also have a bank contract with the Jubilee. And the Jubilee also manages all the cross-charging between boards in terms of the payment for the exams. They charge for the exams and they pay the reporters, and that all goes quite smoothly. So there's a cost-effective model, cost-neutral model between the boards and the reporters. The boards essentially just pay for the reporters' time to do the work. Currently, the systems, the workstations, and the team are all funded by the programme. However, recently we have just had approval that will become just part of the normal service now. So we have ongoing funding for everything, for the workstations, for the IT, for the team, which is really, really good, exciting and really good news. So we're just transitioning from being a pilot into a business as usual service over the next few months. These are just a bit of show off these stats for everyone to see. If anyone looked at the stack on the NHS event, you've probably seen these already. And these are just 12 months. So the pilot ran from July last year to the end of June this year. Like I mentioned previously, we've done 60,000 exams for the system. These exams are all non-urgent routine exams. So they're not anything that comes in through E&E or anything needs to be reported urgently, purely because at the moment, and as part of the pilot, our workflow managers and workflow support officers, they work 9 to 5 Monday to Friday. So if anything happened outside hours, there'd be nobody there to sort that out. And just there's a small breakdown there of CT, X-ray, and MR. So you'll see that x-rays are the most populous. There's 31k, but actually they don't take that much time. So 50% of the work actually comes from CTs, closely followed by MRs. So 16,000 CTs and 13,000 MRs. I think I mentioned previously that we've had £548,000 of cost avoidance because the boards aren't paying their third parties. One thing we are really ecstatic about is the 99.6% of exams are reported within our SLA of 5 working days. A huge achievement by the team and the reporters, and we've been consistent with that throughout the pilot, and we hope to stay up there when it moves to business as usual. We had eight health boards actively donating exams. Oh, and I forgot to mention that during COVID we actually set up, we were able to support Louisa Jordan during COVID as well, when that was open, and they donated exams from when they were open in October until they closed in March this year. And there's just a list of all the health boards that are actually donating to us, just in alphabetical order. Nothing exciting. So yeah, on the right hand side we had 50 home workstations, and then we also had the 32 COVID workstations. Actually, since then we've had budget for another 25 workstations, so there's huge demand for these workstations, and luckily we have secured budget to get these in, and we're in the process of deploying the last 25 now. We've got 58 consultant radiologists working, well, we had 58 radiologists working for us at the end of June. We've now got over 60. One of our objectives was to develop specialist networks. We haven't quite managed that, but we have managed to set up specialist work lists. So there's no ability, or there's nothing in place at the moment for somebody to report on a specialty within their contracted sessions, or have a job plan that where they do some national work and some local work. But what we do have are specialty work lists, where essentially, for example, these 3 areas, neurology, mammals and paediatrics, they'll go into a sole list, and radiologists with that specialty will be able to pick those exams off those lists, and it's only open to the people with those that skill set. Again, the donating boards have been really happy with us. So we sent out a survey, and 90%, we had 90% board satisfaction across all the questions we asked, which was good. They're really happy with the team, with the interactions, the type and quality of the exams, and mainly the cost as well. In terms of consultant radiologists, 9 out of 10 were satisfied with their experience. I think people always want to be paid more. That was one thing that came across in one of the questions, and some people did have some problems with being set up and actually getting a contract, which affected that score a little bit, but we fixed that now. We had 1 host board and 1 team. And that's the last. So now we're open to any questions.
Wow, phenomenal success, and huge congratulations to all of you, and a super presentation as well. But it's just, I'm astounded at just how successful it's all been. What has been the driving force behind it?
I'm happy to take that. I mean, I think a lot of it's leadership, really. It's about we've got a really enthusiastic director who has really pushed this through, and I think radiology, you'd said earlier before we started the call that you normally have conversations with doctors and nurses and people presenting, and radiology is really bottom of the heap every time. It's something that people don't even think of becoming a radiographer as a career or anything like that. And I think it's really about time that we shouted about the success of radiology in Scotland. As I mentioned earlier, I think we were the first country to get a national PAC system. There is a few that have followed now. It's a phenomenal success, and yet you don't really hear about it. No. And I think we really need to take radiology into the next era and give it a much higher profile. So there's been a lot of people within radiology departments wanting to get behind this project and support it. a lot of negativity as well, because people don't like change. And we really have kind of brought everybody on board, even the doubters. So it's just really been a lot of really good teamwork and collaborative working with our stakeholders.
Fantastic, fantastic. I sneaked that one in there before the first question that's come in. Louis asking about secure access for physicians when they're working at home. How do you create that setup?
Okay, so all the secure access is provided from the local boards. So it's either via, it's normally through local VPN solutions that we work with boards in order to provide for these workstations. And we also have like homework station policies about what they can and can't do in their workstation, where it has to be placed, access to it, getting patching, etc. done to the workstation as well. That's provided on a monthly basis. It's all across secure SWAN network links across Scotland. And although radiologists across Scotland before we started this pilot did report off their laptops, we've really kind of been pivotal in putting workstations out there and making sort of proper diagnostic ability to report from home and have access to, as Jen said, also to their local reporting systems as well as our own, which gives, it's a kind of win-win for the boards and ourselves, that they can get extra work out of radiologists working at home or isolating or whatever, as well as them doing work for the NHS Bank.
So I mean, you did mention COVID during it, and obviously a lot of this has happened during that time. Do you think that the situation has accelerated what you were doing, or has it been a hindrance in any way?
Jen, do you want to pick that up?
Yeah, no, absolutely. It's not hindered us at all. I think the only thing might have been trying to get into the hospitals sometimes to go and set up the workstations, but again, it just required making sure that we, went ahead of time to ask for access. And we've been really, really lucky. I think with funding, we had funding for the programme. And like Mo said, we did have quite a few naysayers at first. When we first bought 50 workstations, we were told we were crazy. We actually tried to reduce it to 40 with the supplier because we were told there'd be absolutely no interest in working from home because a lot of the radiologists already work for the third parties. And why would board want to send it to us, if we don't have anyone there? So I think it's word of mouth as well. We had 8 people join us in July last year, and now we've got, I think it's 61 or 62 as of today. We've actually got more radiologists than we do available workstations at the moment. We do have a waiting list in place as well. But yeah, we've been really, really lucky. I think I mentioned with COVID, with people being stuck at home and are not able to leave for various reasons. It really, the word got out there that we were giving away workstations. We had workstations available, and people really, really jumped on that. And you could see where the conversations were happening, because all of a sudden you would have an influx from a certain board or a certain department, and we actually struggled at one point to think, well, how do we divvy them out? Is it on first come? It had always been first come, first serve, because there really wasn't a lot of interest back at the start, and all of a sudden we were overwhelmed by applications. So no, it really has helped us, and I think also by going online and everything being on Teams, it was very easy to have big decisions made, because senior stakeholders were available for meetings. You didn't have to travel the length and breadth of the country. You didn't have to wait for someone's availability a few months later. So we were very lucky in that sense, and to have things signed off and to go into a business as usual model in the coming months really was a pipe dream a year ago. But it's hard actually when a lot of departments or a lot of funding has been cut for COVID, and you know, people have had a really tough time work-wise, of course, and all the hospitals, hospital staff, and you know, personally. But we really have had the opposite experience, and we're really grateful for that.
That's tremendous. I'm being attacked on one side by my spaniel. Excuse me, Lou. Remove that situation. All this homeworking. So it's Louis also has asked about any sort of patient negativity. Are the patients even aware that it's going through a different route?
So boards need agreement to send work out to other third-party suppliers, but they have been doing that for many years. So there hasn't really been, because they've already conveyed that, even though we're an NHS supplier, there wasn't any more communication needing to go out from that. So we've not really had any feedback from the patient side of things as to that they've got the reports quicker or whatever, because I think especially during COVID times, no one really knows how quick they're going to get turnaround on reports for. As Jen had mentioned earlier, we're actually just moving the service now. We got agreement just yesterday, finally, that the Golden Jubilee will take this on as a business as usual service. So this, what has started as a pilot service, will now move to the Golden Jubilee and become a business as usual service moving forward. And we're hoping to do a bit of comms round about that, just to make people in Scotland a bit more aware of what our, not just the SNRRS service, but what SRTP, the whole transformation programme, is doing for radiology in Scotland. Because once again, as Scots, we fail to shout from the highest mountain exactly what we're doing, and we just kind of say, oh yeah, it was nothing. But it really has been, you know, we make it look easy on slides, and it's the same with CDS and AI. There is so many obstacles that are put in your way, and it has involved so much work from all the team, and times where we've thought we'll never do this. So for our project to be really successful, I think has boosted the rest of the projects within the Scottish Radiology transformation. I don't know, Adam, if you agree with that, but sometimes seeing other people's success makes you kind of more keen, doesn't it?
Yes, yeah. I mean, the CDS project itself was impacted by COVID. So we took a hiatus because obviously diversions needed to be made with resource in order to, you know, CDS was not high enough priority. But what we are now seeing is things like CDS and AI coming to the table strongly because of the role that they will play within redeployment, and also what's the word I'm thinking of? Recovery, the recovery plans that are in place. These are the sorts of tools that will help with that.
No, it's tremendous. I mean, I rarely get to speak to such a successful project team. You know, it really is amazing what you've managed to achieve. What was the most technically challenging part of it?
From an IT connectivity point of view, it has definitely been getting e-health departments time. E-health departments, again, are like departments in hospitals that never get any kind of resource. They're always bottom of the pile for getting things sorted, and all that happens is the rest of the hospital piles on more and more and more projects to them. Half the time I think they're not even aware of projects that have been taken on by other departments, and especially during COVID, e-health departments have just been, you know, under so much pressure to deliver, and I think getting e-health resource, even though we involved them right from the beginning of all our projects, you know, a national project tends to come bottom of the pile if it's not like the most important thing for that board at that point. So we just really had to keep chipping away and, you know, taking a back seat when things got critical in hospitals, and then going back and representing things and all the rest of it. So we are really, really grateful to all our stakeholders, but especially the time that e-health and IT departments have spent on this due to the resource.
it's also, I mean, I'm sure you've had similar experiences, but we all see pilots coming and going, particularly in our own local areas, but they rarely spread across nationally. So again, it's just another area in which you've excelled in managing to do that. What sort of learning points would you give to other people who've got pilots and that they want to look to go to business as usual?
I don't know if you're going to speak there, Mo.
I was passing it over to you, actually. Sorry.
My camera, I can't switch my camera on. I lost connection and it wouldn't allow me to switch on again. Advice, I mean, I think we've been lucky. We've got a very positive team, a very proactive team. And I think what we realised early on was that, you know, you have to treat every individual board as just that. There's no one national solution. You can't just develop something for one board and assume that is going to work for every single one. It won't. Not, you know, there's a different set of people, there's different hierarchy, there's different availability, different priorities, you know, different systems, everything's different. So I think it's just acknowledging that and actually trying to work with the boards to see what's feasible, and then that will help you prioritise. I mean, I think this has been a long time coming. It is a great success and we're all really, really excited and proud to be part of it, but it's not happened overnight. You know, I think things we haven't talked about were, you know, even things like setting up a payment model. We had to, before we could do any of this, we had to figure out how we're going to pay people, and that took a long time because the outsourcers actually pay per case. And we tried to have that agreed, but that wasn't. So again, that was like another, I don't know, year or something to get that agreed. So there's been a lot of things going on in the background. And you know, on top of the IT connectivity project, as Mo said, has actually ended up running in parallel with the things we were doing because it just took so long for everything. And of course, like Mo's mentioned already, local projects take priority over anything national. So even when you think you're up there, you're, you know, next in the queue, something else will come along, and that would derail it for a while, or it'd have a knock-on effect on someone else. And but yeah, we have been lucky. We've got a really, really passionate team, really proactive team, really great management as well, great visions from our director, and also we've worked to build relationships with the host board, but not only that, with all of the boards that we've worked with, and that has to be at every level as well. You know, we've worked with radiologists, we've worked with clinical leads, we've worked with managers, HR departments, you know, finance. We've got even down to the admin teams are actually sending the exams in, and building relationships has really been key to all that.
As always, isn't it? It is that communications, relationships, and connections with people that make things happen. Just to put a plug out there for DigiFest 2021, I hope you guys are going to put an abstract in for the posters. Which the prizes for which are sponsored by BCS Health and Care Scotland. So that will be opening up probably in October, I would say, because the event is in early December. We've no other questions in the chat, and for me, we usually say, so what's the next step? Are you just going to grow and grow? Is there another aspect that you want to bring on board? What are you thinking?
So the next,
sorry, Jane. I was going to say, so the SNRRS is almost split into two parts: the bank, which we've, you know, overplugged, and that's the bit that's moving to business as usual, and that will just become part of Jubilee's service. But there's also additional things. So we've got a list of projects that we, you know, picked up along the way, and we actually just had to park them. So we want the specialist networks is a huge thing. You know, how do we actually make use of our pool of radiologists and try and connect them so that, you know, there's a like a pool of specialists that can talk to each other across the country and get the exams done so they don't have to be outsourced. Unfortunately, to date, we haven't managed to bring on reporting radiographers to the bank because we can't figure out how to pay them. We're restricted by Agenda for Change. So the consultants are paid a sort of out of hours rate, what's called the National Consultant Bank rate, but there's no such thing for reporting radiographers. So we've struggled to get agreement on what that should be. So that'll be a big part of it. We have just started a project working to see if it's possible for radiologists through the SNRRS to train reporting radiographers virtually. So where there's not the support in the local board, can a radiologist from outside of that board train up support the reporting radiographers training, and that's just about to start in October. What else have we got, Mo?
There, just to give, so that he can give an update on where you think you'll go with CDS and AI, Adam.
Yeah, certainly. So CDS requires order comms, and as Mo has said, with the sort of complex IT infrastructure in place and the differing systems in place across the NHS, our next step is a national, or more of a national converging strategy towards order comm systems across NHS Scotland and the interfaces that will then enable a wider rollout of CDS. So that's currently where we're at. We think we've proved that CDS is a good thing. It's just the deployment now, which is going to be the challenge. And for AI, we will be looking at, again, the best means of implementation, the best solutions that might be out there, and how they're going to be deployed. So how are we going to connect with our various different systems? What are the interfaces for the likes of PACS, etc.? Those are probably the next biggest things that are sort of on the agenda for us.
No, that's tremendous. And again, huge success that you've had, and hopefully that continues in the same direction. Louis has said, what place will an AI-based computer-aided diagnostic to help physicians on their diagnostics? Are there some sort of filter on normal or not normal procedures? That's in the chat there just now. One of you pick up on that one?
Yes. So yeah, so they do. There are filters. So effectively, if we look at the when an image is read, that they will set confidence levels effectively, which is one of the things that we're looking at with this chest X-ray solution at the moment, is the confidence level, and this is why it's going to be passed through and then be read by a radiologist to make sure that that it is being read right, that the algorithm is working correctly. So again, behind all of this, there has to be procedures and processes in place to ensure that the AI is working and functioning correctly. So there has to be regular tests. But yeah, depending on how it works, then confidence, I think the way that this particular product is set at about 95%, which is why we think only 15% of X-rays will pass through, being not being seen by a radiologist effectively, because the normality is set so high. But so it very quickly can pick up it's what they call a red dot effectively, or an abnormality, but it's what are they confident in passing through as normal. So they have set the sensitivity very high initially, and then that's the sort of thing that will be tweaked as the pilot continues to run. I hope that answers the question.
So Jennifer, Maureen, Adam, it just remains for me to say thank you for a fabulous presentation, but more than that, for just such a successful project. To see something like that coming through and the difference it can make is phenomenal, really, for Scotland. And yeah, as Jennifer said, you're rightly proud, and so you should be. And it's been our pleasure to actually have the opportunity to let you shout about it a little bit. A small select audience, but I'm sure other people will watch it later out of our business hours. So again, congratulations and a big thank you. And remember to get that poster abstract into DigiFest 2021.
Well, we'll do it as soon as we. Thank you very much for that.
Lovely. Thank you all.
Thanks, everyone.
Thank you for having us.
Bye.
Bye-bye.